Hello everyone, I am Dr. Abhilash Jain Mansali, consultant physician, geriatrician and diabetologist. Today we will be discussing about thyroid nodules, which are one of the most common problems detected incidentally when we go to a doctor to see or visit with other problems, usually detected while doing CT scans, ultrasound neck, carotid Doppler. These are most common in women and increases with age. Technically, goiter means enlarged gland. So, this problem should be solved judicially in a patient-centric fashion. Majority of these nodules are benign in nature, about 95%, and 5% are only in malignant nature. So, for example, if anyone has a swelling in the gland, they should consult an endocrinologist and or a specialist where we do a proper clinical examination and a proper questionnaire and advise further investigations. Usually, ultrasound neck is the most common preferred modality of an investigation. It addresses USG characterizes the nodule into various degrees and tells about what are the chances of getting an risk to a cancer. To assess the severity of a cancer, we should usually specifically tell a radiologist to do ultrasound neck with special focus on surrounding lymph nodes to be performed. And this ultrasound has to be performed by a trained or an experienced radiologist or who has done a more number of thyroid scans so that they can score as per the American College of Radiology into triad scoring. If the score is low, there are low chances of getting into a malignancy. If the score is high, then there are a lot of chances to go that nodule into a malignant in nature. Once scanning is done and it is suggestive of an high risk, we should do and further tests like FNACs and cytopathology. If the nodule is big enough for FNAC, then we should undergo FNAC. If the size of the nodule is less than 1 centimeter, most of the guidelines tells to observe unless it is suspicious. If the size of the nodule is more than 1 centimeter, then we should do FNAC, which should be done by an endocrinologist or an radiologist using an ultrasound guided. Once it has been done, then we should report these slides to the or smear to a cytopathologist who is also experienced or trained in doing all these things, so that he triages into scoring system which is called as a Bethesda cytology reporting system. In this also, if the score is low, then it is an benign in nature. If the score is high, it's a cancerous in nature. There is another category which is called as a indeterminate, which means that we are doubtful whether it's a cancerous or a benign. During this thing, with these reports, when we go back to a physician, they decide whether what kind of treatment has to be done. Suppose if it is a low risk, we tell them to follow up for every 6 months. If it is a high risk, then there are high chances of malignancy, and again we tell them to undergo a surgery. Problem is with the indeterminate category, where we need a team approach which involves an endocrinologist, radiologist and a cytopathologist to discuss and decide what has to be done in a better way. For instance, in indeterminate category, we redo the FNAC for 3 months to locate and confirm the risk of the malignancy. Other option is during FNAC, we do cytology and we also do mutation testings. If mutation testings are positive, then there are high chances of getting into malignancy. Other option in FNAC, if it is an indeterminate thing, all the things are negative, most of the physicians suggest a total thyroidectomy or a partial thyroidectomy depending upon the clinical scenario. To sum up as a whole, the thyroid nodules are most common nodules which are incidental finding during an clinical examination or a visit to a doctor with some other conditions. These are most common in women and increases with age. Most common and best modality of finding a nodule is ultrasound. With the ultrasound guided, we can score, and the scoring system is called as a Berard scoring, which define about if the score is low, then we tell it as a benign in nature. If the score is high, we can tell it as a malignant in nature. Once this is done, the other option is we do FNAC. In FNAC, if the FNAC uses an experienced cytopathologist reporting, where we use an Bethesda scoring, which tells us about low, high, and indeterminate. If it is a low scoring, then it is a benign in nature. High scoring, then it's a cancerous. And if it is a indeterminate, we redo the FNAC or we use a genetic mutation method, which is the most advanced technique. Thank you all.